Okay, I'm just gonna start now.
Yes, please. Good afternoon, colleagues, and welcome to our special edition of our TB Think Tank webinar with Professor Norbert Ndjeka, who's going to be walking us through the National TB Program Strategic Plan. Welcome, Prof. I just want to run through a brief bio of yours, but I'm sure you certainly don't need any introduction. So Professor Ndjeka is a prominent figure in the fight against tuberculosis, known for his dedication and innovative approach to the TB control program as well as management. He's currently serving as the Chief Director of the TB Control Cluster at the National Department of Health, and he has a wealth of experience and expertise in this field. With a background as a family physician specialist, he's made significant strides in reducing drug-resistant TB cases in South Africa and improving treatment outcomes for patients with drug-resistant TB. His leadership has led to a remarkable increase in the proportion of patients successfully treated for this challenging form of TB. In addition to his practical achievements, Professor Ndjeka is a prolific writer, having authored numerous articles in prestigious international scientific journals. He has also played a key role in developing treatment guidelines and training modules for drug-resistant TB in several African countries. Recognized for his exceptional contributions to the field, Professor Ndjeka was conferred an honorary doctorate by the University of Cape Town and appointed as an honorary associate professor of medicine at the same institution. His work continues to inspire and drive positive change in the fight against tuberculosis, both locally as well as globally. And we are extremely fortunate to have him today to present. He's also the chairperson of our TB Think Tank Secretariat. A warm welcome, and over to you, Prof.
Thank you. Thank you so much, Priya, for the introduction. I really need to start with a thank you message to the TB Think Tank and all the colleagues who've worked very hard to produce this. Are you able to see my slides?
Yes, Prof, you can. You can just put it on slide there. So.
Okay. All right. Yeah. So I really thank all the colleagues for this work that I'm really presenting. You know, you can see this is an overview of the National Strategic Plan for HIV, TB and STI, and the TB Strategic Plan 2023-2028. It's the work of so many people that worked on this, and the TB strategic piece was well executed by the TB think tank that brought us together, and for several months we worked together. We produced this. I also thank WHO that produced guidance for TB strat planning, which we also followed. So my presentation will be looking this way. I'll give a short background. I'll talk about the National Strategic Plan, vision, mission, and guiding principles, and the goals. I'll look at the objectives and the national target, and show alignment with the TB strategic plan. I must say that the alignment is very clear. You will see between the NSP, which we call NSP, and the TB strat plan. You know, when we say NSP, we refer to the National Strategic Plan, which was approved by our cabinet under the SANAC leadership of Mr. David Mabuza. He was the chair of SANAC at that stage. And Cabinet approved this after extensive work. A lot of people were asking, why do we need a TB strat plan in particular? It looked like we want to go back to the old arrangement, because in the past we used to have a TB strat plan alone outside of the HIV. But the reason why we did this is because with the previous HIV TB STI strat plan, we were the problem assessing progress for that strategy NSP. Hence, we felt we should take the NSP language, put it in the TB language. You'll agree with me that the NSP is really for all government departments, for the entire government, our national strategic plan for HIV, TB, and STI. But the TB strat plan is focused more on the national TB program and those who work with us very closely. So that's the reason why we had to do this, but I'll show you now that the alignment is very good and we're very clear that these two documents are actually one document. South Africa is a vision of a country, South Africa, free from the burden of HIV, TB, and STI. So our mission, therefore, is to track, to really try to eliminate HIV, TB, and STI as public threat by 2030. There are other strategies that talk of 2035, but it doesn't really matter. We have to eliminate these conditions. It doesn't matter, is it 2030, 2040? We really have to work very, very hard. And some of the principles that we have to follow that we need to put people and communities at the center and think, be patient, people-centered, provide people-centered health and social services. Universal health coverage is critical. We're one of the most unequal society. People keep saying that. So universal health coverage is very important. And NHI is probably one of the vehicles to achieve that. Obviously, how would that be achieved is still being discussed, but I think the legislation in place gives guidance. But the detail will really be in the implementation. So it is very important then to consider that the multi-sectoral approach is very, very important, but commitment cannot be replaced by other things. There's no shortcut to this, and we evidence-based in terms of whatever we want to do. So these are the key principles that guided our NSP, which has the 4 goals, as you can see, in terms of breaking down the barriers to achieving outcomes for HIV, TB, and STIs, maximize equitable and equal access to services and solutions for HIV, TB, and STIs. So these 2 are really very, very important goals, but we also want to build resilient systems. These are the type of systems that will continue to render services even during a pandemic like we had COVID. We know that we had a big problem with the case finding that dropped by 20%, linkage to care and all that during COVID, which meant that a lot of our services are not resilient, our systems are not resilient. So we now have an opportunity to build resilient systems that are fully funded, that have enough resources to achieve the mandate. Sometimes the question of resources has to do with how resources are utilized. So maybe just to show some of the objectives in terms of breaking down barriers to attaining outcomes, the issue of strengthening community-led responses is very, very important. Dealing with poverty, contribute to poverty reduction is really critical. We often talk about social support for TB patients, HIV patients. Stigma is a problem because it restricts access to care, but also gender inequalities is another problem that we have to deal with, because while we know that sometimes females are badly treated, they can't access healthcare services, but also sometimes the arrangements at our facilities, so many female persons from the chief matron to the most junior clinic nurse, it can also be a challenge, has been documented in some studies, that this can also be a problem for male attendants to services. So all these are things that we really need to consider. And you can see TB is really in here. Issues around access, you find that we talk about increasing knowledge, attitude. A lot of studies have shown that many of our people in the country don't know how TB is transmitted, what should happen with treatment and all that. So these are the key objectives, most of them really related to HIV, but you can see TB prevention is mentioned, TB diagnostic, treatment, care and support, very, very critical. And these are some of the objectives that we lifted and decided to really unpack in the TB strategic plan. So that's the exercise that we did. In terms of building resilient systems, you can see these around human resources. I mean, without people that know what they're doing, you can't do anything. But you must also use timely and relevant strategic information for data-driven decision-making. Big problem here with current transition from where we are to the electronic medical record. We still have some challenges there, and is always work in progress. So let me kill this. So the issues around technology issues around technology and all that are very, very critical, because in the era of digital, we live in a digital world, but we struggle to move from paper-based operations to embracing technology. The infrastructure is critical, and all that supply chain issues we have. So these are the objectives of this plan to help us with all this. So what we did also was to look at issues like, for example, laboratory for TB, because then if you say that you want to find TB to end TB, you need to invest in your laboratory services. But we world leaders in introduction of new tools, new products. So it's really critical that we lift in terms of TB, what are we doing? So regarding resources, the 4 key objectives are here. Now, this is really overall in terms of mobilization, allocation of domestic resources. We also want to get more money from the existing international funding. We want SANAC to be positioned to be able to make sure that these funds are located in the right places. And it starts with a good mapping of all these resources, who's getting the resources, what are they doing with the resources. That's very, very, very important, and we're working hard towards that. The good thing in this area is that we now have a multi-sector accountability framework, which we have started to implement. it is approved. We've had recent discussions with SANAC in terms of what do we do as health department, NTP, and what do other state departments do, So I'm sure in the next few weeks, SANAC will make that information public. We also had separate meetings and joint meeting with the SANAC TB Civil Society Forum with them in terms of our TB recovery plans. What are they going to be doing? So that when we have our meetings, we know exactly what are they doing for TB, and we will tell them what we're doing, and then we make plans together. So all these are things that we're doing because of this plan, but they've also, the SANAC Civil Society Forum has also expressed their desire to be part of all the TB Think working groups, so that they participate and add to that. So I thought that was really something that is critical, that will help us to achieve our objectives moving forward to enhance the fight against TB. The issue of key and priority populations have been looked at in the document. I don't want to go back to this, you know this very, very well. But what is really then important, I want to look at the TB strategic plan. Now that you're clear in terms of where is the alignment, I just want to start by saying that the pillars are pretty much aligned with the 4 goals of the TB, of the NSP. Communication is critical. We want to really make this a national priority across sectors, and find and link people with TB to care, treat, retain them in care, and prepare and prevent. And the last thing we want to do, not the least important, but this is really critical, monitor and assess. We need data systems that will help us make, decisions that are informed by the data. And this is where we are. If you look at the deaths, I want to decrease the number of deaths from 56, I think we're sitting at 54,000 per year, to 30,000. This is a milestone that we've not been doing very well. Catastrophic cost is 56%. We need to decrease it to 30% by 2028, and all the interventions that I provided earlier on is really what we need, and we'll come back to a bit of details around this. But the incidence notification gap is coming down. We do a little bit better here with the treatment coverage. This error here is 77. I know this was 57. It moved to 78. Percent. I think this, I need to quickly double check this. The last one was 77%. When this is an error, the treatment success should be 85%. So this is where we are, and next year we are working very hard to improve these indicators, and 2028 hopefully get your death rate below 10,000 and improve treatment coverage to above 90%. It is currently at 77 by end of 2022. So pardon me for this error. We fixed this, but it was when we started working on our strat plan. I think it was below, probably below 50%. Let me quickly just, oh my God, what is this now? Sorry, colleagues, I have to disable this gadget. Thanks, I'm done. So now, in terms of the plan itself, before we go to that, I think, like I indicated, with our cascade, there are some improvement in terms of decrease. people of like the missing people, which is more or less what 60,000 or so. But like I indicated, the death rate is very high, and loss to follow up is really unacceptable. The risk groups have been also assessed, and this is the situation. These are the numbers. We need to really work very hard on this. One of the things which I didn't cover here is that from State SA we learned that diabetes is now killing more than TB. So we're number 2 in the country. So this small decrease, but really not what we had wanted to see. Again, nobody has looked at the relation between TB and diabetes, so we're looking at this separately, but the in-depth analysis might show that actually those diabetic patients are also TB. So where do you place them, number 1 or number 2? But whatever way you look at it, TB is really killing a lot of people, and these are the objectives and sub-objectives and key activities under each pillar. Pillar 1, want to improve communication, so leveraging provincial caucuses and TB caucus, and the National Assembly does no longer have TB caucus. So we're hoping that a meeting with Dr. Dlomo, our previous deputy minister, will be organized soon, so that we leverage on this. We need to get a SANAC that helps us, but also engaging all these institutions will be very good. We're working very hard around that, but I think a major thing here for this year in particular, we're going to have to launch an NTP that we hope our minister will launch around November, and really then that will culminate into digital campaign and social media campaigns, and various messagings will then be drafted. I think there's a workshop today and tomorrow that will look at those messaging and everything. We're hoping that will create demand for utilization of TB services. We'll be able to find more people, link them to care, but then treat them effectively and retain them in care. We know that 6 months regimen is really the norm right now, but we even got a more rapid communication, another one from WHO with more 6 months regimen. So we're moving really from a era where we had these long regimens, boring regimens. Now the problem is going to be which 6 months regimen should the clinicians use from next year. So prevention is critical. The use of UVGI light, I think the TB think tank has been working on this. Maybe we can discuss about the LED item, the lights here, but definitely this is critical. We want to prepare for introduction of an effective TB vaccine and strengthen digital systems for TB. So these are the areas that we are really working on. But what I can say is that this plan is a 5-year plan. So what we do, we pull in items, various items each year. We use our TB recovery plan as a vehicle for implementation. So this is what informs what we do in the TB recovery plan. You'll agree with me, we can't do all these things in 1 year, but based on the priority also as informed by the TB think tank and the provinces and various stakeholders, we pull priorities from this list, and we then implement on a yearly basis. Let me move to my next slide in terms of what we're already doing, what will continue, and what will be introduced. This is going to be really work in progress. More new shorter regiments will are expected to be introduced next year, like the new MDR 6 months. So it's really exciting, but also the fact that the research was conducted locally makes me even more happier, more excited. So in a nutshell, better communication and cooperation across our sectors is what we expect. Person and family-centered, better occupational health and support. We also want initiatives to understand and reduce treatment and vaccine hesitancy, because we have one of the highest loss to follow-up rate. Interaction with communities and politicians, we really are trying our best with this. Referral systems, linkage to care to be improved. Quality of care has been said to be bad. We really have to come together and work very hard on this. Interoperability of data systems is critical until we get a functional electronic medical record, not just for TB and HIV, but for the entire health sector. And this is going to be one of the key pillars of the NHI. So EMR has to succeed. We must all support it. Is really a data system for the entire health sector in South Africa. And dashboards are important for people to watch, to observe, to know what's going on. Then they can be they can be contributing. So these are some of the things that will be coming. Issues around sequencing, for example, the targeted next generation sequencing. Working hard for this so that we get to know, for example, bedaquiline resistance, but not just bedaquiline, linezolid resistance and all this. Very, very important. Community-based care is very important. Palliative care, we used to be strong in this. Then when we got ARVs, we felt that maybe it's no longer needed, but it's not true. Some people will need this. Social support is critical. Of course, we need vaccines and improve also pediatric care as well as the pediatric vaccine. So in the nutshell, this is really what I thought I would say. These are just targets for programs. We've identified these objectives to be achieved and the various indicators in terms of the TB caucuses. This is critical. TB notification, loss to follow-up, treatment. These are the various indicators that we use. We're using to monitor performance around this TB recovery plan, which is a vehicle essentially to implement your TB strategic plan. The cost has been really done by the experts who are doing the TB, the NSP. So we pull this information from there and really to meet those needs, we do what is recommended. We need 4 to 5 billion rands per year, and we know what is more cost-effective interventions around our TAT, finding TB, linking to care and all that. So we know these things, we know the cost, we know we've been here, but from the indications I got, scratching into all the pieces, it's not like NTP has 4 billion, but these 4 to 5 includes, for example, PEPFAR money contribution to TB, the TB Accelerate, the Global Fund contribution, equitable share to provinces, conditional grant. We've checked and we are reliably informed that there is at least 4 to 5 billion rands per year that gets allocated. Now, what we don't know is how is that utilized. So moving forward, that is going to be really critical. That's something that we need to do. On that note, I thank you, Chair, and I'm available to take questions. Thank you.
Thanks so much, Prof, for that excellent presentation. And you'll be happy to know that someone on the call has been part of the TB think tank is Sanj, who's played a very critical role, as you know, in the engagements, the consultations with the provinces, as well as instrumental in the development of this NTP strategic plan. And Sanj will just take any of the questions and field the questions here on after. Over to you, Sanj.
Thank you.
Thanks, Priya. Hi, Prof, and hi, everyone. So I can't see any questions in the Q&A at the moment or in the chat. But if people do have things that they want to talk about, please do put them in there. So I have a couple of things just to get us started, if that's all right, Prof. You talked a bit about aligning with the MSP that you did during the strategic development process. And I wondered, just in terms of as moving into implementation, how much SANAC and people who were involved in the MSP is the communication still a priority in that sense, or is that mostly for the development process and now people go off and do their own things a little bit? I wondered just if you could speak to the communication structures around implementation a little bit.
Okay, thanks a lot. I think the communication, maybe I really need to start by thanking you for your contribution, Jody and the other colleagues. You know very well that before we could finalize the pillars, we really had extensive discussions in terms of do we need communication as a pillar? Do we not need it? It was like we don't need it. Yes, we need it and all that. But I must say what has happened to that pillar is that we made big progress in terms of communication. We got a technical support unit that is funded by Bill and Melinda Gates Foundation through Genesis. They've hired a advisor for social behavioral change communication who came in, and we've been interacting with stakeholders. We now have a End TB campaign, which is still in-house. We developed this idea. We're now ready. We started sharing with provinces and other key stakeholders. We have a My TB Story platform, which is an electronic platform where people who have had TB post their stories online, and it has been very, very exciting. Although it's still small, but I look forward to more stories. But also what happened is that so when we launched our BPAL, the 6-month MDR regimen, we brought in a strong communication component. We designed a specific poster, a few posters that we disseminated in the Eastern Cape and in the country. And because we got like data on those who were cured very fast, we've been able to bring those TB champions who got cured from our recent 6 months regimen to come. So we've had a national engagement. We invited some of these TB champions to Durban to our meeting. They spoke, and we've had an event, provincial event, in Eastern Cape and Northern Cape. Now, what I can say is that from our pillar and from our commitment to improve communication, I've noted that now the standard of our event is that we bring a TB champion to address the audience. That's something we didn't do it before. But whenever I plan any symposium or conference, even if I forget, someone will say, can we bring a TB champion? And the provinces are doing it. We're doing it nationally. I thought this is really critical around this. And we started a discussion on community-led monitoring within the TB program, working with other stakeholders. And everybody is unanimous that we need to introduce the One Impact platform to work with civil society and all stakeholders. So it is, for me, it's just big, and I see us going quite far with issues around data, around communication, advocacy, and communication. Thanks.
That's brilliant, thank you. And yeah, I was at the meeting in Durban and saw the kind of event where some of the TB champions spoke. It was really amazing. So it's nice to hear that that's sort of becoming the norm now, that people get a chance to speak at meetings. Thank you. So there's a question from someone in the audience. I'm just going to read it. I don't know if you can see that, Prof. So they say, start by thanking you for the excellent presentation. Monitoring of adherence to TPT is not being done. Pill count is the best method. What is the status of an electronic monitoring tool? And that's from Marty van Dwelp.
Okay, no, thanks a lot for the question. Thank you, Marty. So I agree, monitoring for TPT is a problem. I think one of the challenges we have has been like the money in country is not been possible to get like all the data and all that. The process to get indicators around this and monitor nationally is really difficult. It's still work in progress, but we haven't managed to win the battle in that area. We have very little data. Part of the problem also is that we cannot say what is it, HP, is it IPT, is it GRTB, TPT. Very, very difficult. Maybe we need to plan some research project to look at this. Regarding electronic monitoring, we're not doing it. There haven't been really consensus in terms of what electronic tool to use. I think even I don't know. I don't think I missed this. Even from the TB think tank, we've not really had a consensus. We've not reviewed data that really push us to say let's use this. And I hope that we need to continue doing more research in this area. I'm personally happy to have electronic monitoring, but I would be happy to get a clear recommendation from the TB think tank so that we take it to our funders and put it in the plan. To date, we haven't had a consensus around that. Yeah.
Thanks. So there's a question from Harry Hausler. I don't know if you can read that.
Yes, I see the one.
You can.
Question around the One Impact rollout. Yes. So this is this is really something that we want to do. Last week we have had engagement with key stakeholders in the country to do three things. We dealt with domestication of TB in the mines. And for the first time, we've had all the relevant state departments, with the most senior officials responsible for this, from Labor Department, Department of Mineral Resources, Energy, Mining, Mineral Council, just really the, all the people we've ever wanted to meet with, including SANAC in one room, all guided by EXA as a service provider funded by Global Fund. But next door, we are the community-led monitoring. And then this is really a discussion that we've been having with for example, TB HIV care. We are aware that there's a project there that is running, but we felt that we need to make this big, to bring in SANAC and all the stakeholders, so that we get this implemented. We need a plan. I've asked Pumlani to draft a plan which we will circulate to all stakeholders, because we also circulate a plan on the domestication of TB in the mine, the cross-border referral system, but on the one impact, this plan must go to SANAC and all stakeholders. We need to agree on how will we do this jointly. The program will support, and we want the stakeholders to be properly funded. We've had CDC being happy to fund this from next year. So we like to believe that from the consultation with SANAC and all stakeholders will be knowing that this is how much we're getting as a country, these are the NGOs that will get, this is how we're going to do it, and reports will be coming regularly so that we scale up this to other places. And we also need to get this factored in the Global Fund GC7 proposal, so that we have sufficient funding to the NGOs that are doing this. Of course, we want to keep those that are already do it, and help the newcomers do properly. Our problem has never been really getting funds, but I think the biggest problem we have most of the time is give funds to people who don't know what to do, and then they waste time trying to understand how this is going to do. So there is already experience in the country. I've had extensive discussion with SANAC, with TB Service Society Forum. We very clearly want to do this, and one of the things we want to do is have a webinar with the colleagues in Nigeria. They do it big time, they do very well. The Stop TB Partnership invited us to a meeting in Nigeria in December. I haven't forgotten that. I'm just hoping that maybe from TB HIV care and some of our civil society forum here, we can go to that meeting and witness this. It's something good, so that we don't have a system that find problems for publications. That won't help us. We want a system that will identify problems and resolve problems. So if you have community find problem, they should know who are they going to talk to at the clinic, at the district level, and they begin to work on that. That's how I saw it work in Nigeria and in DRC, and they don't have problems. Because then if at their level they can't resolve, they escalate it to district or province or national, again using the existing channels. And in some of these countries, these CLM work from government buildings, from NTP buildings, where they are supported, they are partners, of course, but they do a job that gives benefit to government, and they are working together. So that's really how we want to do it. I'm waiting for the draft plan. I know EXA will send us recommendations. We'll look at it and we'll take it to SANAC. We want SANAC to coordinate this in the context of multi-sector accountability framework. Thanks. Yeah.
Thanks, Prof. Actually, so can I just clarify one thing? It's CLM community-led monitor, something like that?
Community-led monitoring, yes.
Monitoring, okay, thank you.
Yeah.
And actually, just while you were talking about kind of international cooperation around this, you talked in your presentation around building resilient systems. I initially misheard you, and I thought you said Brazilian systems, which actually wouldn't be a bad idea because Brazil have excellent data systems. And I know there was a BRICS meeting, a TB BRICS meeting a while ago, and I just wondered if anything that had come from that meeting is sort of influencing the way you approach implementing this strategic plan.
Yeah, no, thanks a lot. Now I was talking about resilient systems,
yes,
but
no,
what
I
about the
that.
Brazilians? I mentioned the Brazilians. We had a Stop TB partnership meeting in Brasilia, and they took us to some of their sites where they treat TB and other infectious diseases. So yeah, no, the systems are quite good. There are quite a few things we learned from there. For example, the meeting where the NTP Nigeria and the NGOs that are using One Impact presented, it was in Brasilia. I was really impressed, and I spoke to CDC colleagues from Atlanta. I spoke to the One Impact guys. They were very excited. They said, no, I want to support you, want to do this. And this meeting happened early this year. It was a Stop TB partnership meeting from Brazil. We working with the Brazilians, preparing for the G20 meetings and all that. So there's been a lot of exchange with Brazil. Last year, we had a BRICS meeting in Durban. We also had a meeting in Moscow in April this year. The BRICS, so last year was the BRICS TB Research Network in Durban. This year we had a meeting in Moscow with the Brazilians, and yeah, a lot of good things come from Brazil. Russia is also doing well. China's got amazing stuff. So yeah, we really work very hard to take some of these systems to the country, but we're also preparing for G20 next year. So South Africa will have the presidency of G20, and we're preparing an event that will showcase some of this hard work that we've been doing. So we've got to share with the rest of the world, the work we're doing. Look, we got these plans. We've integrated TB, HIV, NSP. We've got a powerful TB strat plan. These are we implementing it through the TB recovery plan. There's a meeting with WHO. So we're contributing to the Brazil this year for G20, but our G20 meeting will be next year. So we see the Brazilians a lot. They will come next year, and we're going to have side event with key stakeholders, and yeah, we learn from them. But we need resilient systems. Within the DOH, we have a pandemic preparedness team. I'm part of that team. We're working with WHO as well, and yeah, plans are at an advanced stage. Yeah.
Thank you. So there's a few more questions coming in from the audience. I don't know if you can see them. So there's one about diabetes and TB. I don't know if that there's more. There doesn't seem to be a real question in there, but I don't know if you want to comment further.
Yes, I think the issue of TB and diabetes, we know from literature it's a problem. I'm convinced part of the mortality we see among our TB patients is due to diabetes, but we don't have solid data to really explain to what extent this is happening. So I think this is one area that we need to prioritize at some point, as we implement our TB recovery plan. We haven't really prioritized things around TB and non-communicable diseases, mental health, diabetes, and all that. We need to improve maybe the next recovery plan. phase, we need to look at that. At this stage, I don't have a lot of information around this. Part of the problem is also inability to collect data on who's diabetic, what are the outcomes, and that, yeah, it's something we need to work on moving forward. I see the other question is around the public-facing dashboard.
Yeah.
We don't know when. This has been the request from Service Society. I spoke to our colleagues who are responsible for digital health systems, and they said, and we even looked at the Western Cape one together. They indicated to me that the dashboard we see in the Western Cape has been prepared over many years. So to do it at national level is a bit difficult at this stage. So we now in the TB program within our technical support unit, we are exploring a option of going with something not exactly like the Western Cape, something we're working on something which we can, and I think TB Think Tank has been part of this discussion. We really need to come up with something between TSU, TB Think Tank, maybe early next year. So we're working on it. There must be a dashboard, but it won't be an advanced one. But it's better to start somewhere, and that's what we are going to do. Yeah.
Okay, thank you. There's another question about TPT community initiation for TB contacts.
Yeah, TPT is critical. We really want to do it. Like I indicated, our inability as NTP to measure that intervention is a big problem. And it's not the decision of the TB program to change indicators that are collected. We have to, you know, work with other colleagues within the health department who have to do this. There have been discussions on the needs indicators, and I think for me that's a big problem to collect indicators, but nevertheless it is happening, but particularly on the community initiation for TB contacts is not something that we do very well. I think TB contacts is not even done very well. Probably it's something we need to sort out, and we can explore this during one of those WHO Green Light Committee reviews that are done every year. There'll be one this year. The last time I was looking at the EDR web, I saw that the EDR has changed. We collect information on EDR web, or on TB contact on EDR web, for example, and the risk is also allocated. But then we go further to ask whether they got TPT, you know. So that is data that is available. Maybe if we can look at it through TB Think Tank, to the group that is looking at it, just to understand. To me, it was very interesting. Most records are looked at, despite the contact being at high risk of getting TB, were not, they didn't have, so it was about testing or TPT. You have to test them, and if they don't have TB, then you give TPT. So these are things that I noted are not done very well on EDR web. So it's something we can explore within the TB Think Tank and provide a solution. Thanks.
Thank you. So I think there are no more questions from the audience. We've just got a couple of minutes left. Okay. I wondered if, could I ask you one last question about vaccine readiness and some of the preparations that are going on there, or some of the work that's been done?
So regarding vaccine readiness, we formed a TB vaccine working group within the National Advisory Group on Immunization. So this group is meeting regularly to evaluate evidence around this in preparation of an effective vaccine that might become available at some point. So we're preparing around that. We're invited, I received an invite to present in Brazil during the TB vaccine conference in October. We submitted through TB Think Tank an abstract in terms of our effort to prepare for TB vaccine, to deal with responsible communication around this. And so that abstract has been accepted. They invited me to present during the plenary in Brazil in October, 8th of October this year. So yeah, work is happening. We're not making a lot of announcements, but we're engaging with research leaders at this stage. And when we come across something interesting, we'll start opening communication to other stakeholders. So, but we're working very hard. We're preparing for that. Thanks.
That's great. Thank you, Prof. So I don't think there's anything from the audience, and that's the end of my list as well. So thanks so much for the presentation and for your time. I'll hand back to Wazi to close the session.
Thank you so much, Sanj. And again, I'd also like to say thank you so much, Prof. Ndjeka, for your time and for your presentation today. And to those in attendance, thank you for joining us. And please do join us next week, Monday, at 12 noon, of course, for our session that is titled Urine TB Tests for Patients with HIV, an Expanding Diagnostics Landscape. Please do enjoy the rest of your day. Thank you so much for joining.
Thank you. Thank you and goodbye.
Bye.